Welcome YouTube, I'm Aniket and you are watching Vet Study. So today I'm going to discuss about the acute inflammation. If you haven't watched my last video, Introduction to Inflammation, then please do watch that video, link is in the description. So start with acute inflammation. In acute inflammation you can say this is the first phase of any inflammation. After acute inflammation there will be the chronic inflammation. Okay, so acute inflammation is very important, and in acute inflammation there are several phases which we will discuss in this video. So let's start. First, in acute inflammation, what are the principal cellular and vascular changes, vascular responses which occur in the acute inflammation? So in acute inflammation there are changes in the blood vessel. We will say this vascular response. Okay, so in arterioles there are changes, and in capillaries some changes also occur in capillaries and venules. So first we will discuss with the arteriole changes. In arteriolar changes there is arteriolar constriction, right? So when the endothelium cells of artery they constrict, what will happen? The transudate will exit the blood. So what is transudate? Transudate is nothing but it is a fluid with minimum protein and cellular element. It is somewhat similar to the plasma, but it has minimum protein limit and minimum cellular element, and it is essentially an electrolyte solution. You can say it is an electrolyte solution, right? So this is transudate, and it is somewhat similar to plasma. Okay, so it will exit the blood, and this happened due to the mast cell degranulation. When mast cell degranulate, there are release of certain chemicals, we will discuss it later, and due to which increase vascular permeability. There is increased vascular permeability. Why there is increased vascular permeability? Because of some chemicals which we will discuss, right? And after this vascular permeability increased due to the endothelial cell contraction. Those chemicals act on these endothelial cell, and these endothelial cell will contract. Chemotaxis for neutrophil is also occur due to this. After these are the changes in the arterioles. Now we will discuss what are the changes in the capillaries and venules. In capillary there is platelet aggregation, you can say, and emigration of neutrophils. Emigration is of neutrophil, as we have discussed earlier, that neutrophils are the first cell in acute inflammation. So there is emigration of neutrophil. Okay, after this there is diapediasis of erythrocytes also. So these are the events in the capillaries, but in venules there is emigration of lymphocyte, infiltration of macrophages, and fibrin deposition. After this fibrosis occur in chronic, so we will discuss it later, right? And all these things form the exudate. So there is a difference between transudate and exudate. We will further discuss in detail. Okay, so this is the process which occur in the acute inflammation, basically cellular and vascular response. What are the cells which leave the blood and come out, and what is the vascular response or change in the vascular permeability? We already discussed in this diagram. Now we will discuss about the major steps of acute inflammatory process. In acute inflammatory process there are several steps and which are important. You should remember these steps, right? In acute inflammatory process there should be tissue damage, and this tissue damage mainly occur due to the either exogenous or endogenous substance. What are exogenous or endogenous substance? Exogenous substance are those substances which come from outside or foreign to the body, right? And these endogenous substances are present inside the body. So you can say either exogenous or endogenous substance. So they will produce what? They will produce the tissue damage. After this tissue damage, there will be the active hyperemia. Active hyperemia means there will be increased blood flow to the injured tissue. Okay, which is secondary to the dilation of the arterioles. See, the first step is the dilation of arterioles, and this due to this dilation there will be the active hyperemia. Active hyperemia means there will be increased blood, right, which is due to the dilation. So this occur, which is also known as the vasodilation. So ultimately your first step is the vasodilation. After vasodilation, what will happen? Vasodilation, and this vasodilation is responsible for the redness, redness, which is one of the cardinal sign of inflammation, and heat, another sign of a cardinal sign of inflammation. So this redness and heat is mainly due to the vasodilation. After the vasodilation, and someone can also ask what are the factors which facilitate this vasodilation. So chemical mediators, like you can say prostaglandins and endothelin and nitric oxide. So these are some chemicals which are released by several cells, like prostaglandin, endothelin and nitric oxide. So they will facilitate this vasodilation. After vasodilation, there will be the vascular congestion. You can also see here that dilation of arteriole. Okay, there will be increased blood flow, and then there is vascular congestion. Vascular congestion will allow the time of fluid to leak through the you can say the vessel, and this is facilitated by a component like C3A, C5A. These are some complement protein. We will discuss it later. Okay, so these are some you can only remember that these are some protein which will facilitate this vascular congestion. Bradykinin, leukotriene, prostaglandin, platelet activating factor. There are several chemicals, right? So you should remember only this, that they will facilitate this leakage, and due to this leakage, when the leakage of plasma and plasma protein, right? Plasma and plasma protein. So this will leak into the extracellular space, and due to the leakage of this all these things into the extracellular space, there will be the swelling. That is another cardinal sign of inflammation, and there will be the pain. Why there is pain in this process? Because there will be the stretching of the pain receptor due to this swelling. Okay, and so these are the different steps. First is the dilation of arteriole, increased blood flow, slowing of the blood flow, and stresses of the blood flow. Due to this, fluid in the tissue comes out, and there will be the fluid component of exudate. So these are several steps. After this, the volume and protein concentration of the leak fluid is the function of basically gap between the endothelial cell, because if there is a less gap between two endothelial cells, then there will be the less leakage of protein. Okay, you are imagining the situation, right? If there is less gap between two endothelial cells, there will be less leakage. It is obvious. And if there is more gap, means if there is more vascular permeability, there will be the more transudate or exudate. Now we will discuss about the what is the basic difference between transudate and exudate. So the basic difference between the transudate and exudate is that, as I have already discussed, that transudate is the fluid with minimum protein content, right? So what is the protein content in the transudate? It is somewhat less than 3 gram, right? But whereas in exudate have more than 3 gram protein. While we are talking about the transudate, the specific gravity of transudate is less than 1.012, less than this, and the specific gravity of exudate is more than 1.020, right? So you can say that transudate is somewhere opaque and viscous fluid. Whereas transudate is the fluid with the low specific gravity. So this is the basic difference between the transudate and exudate. You can understand that there is somewhere difference, and mainly in the protein. So there is more protein in the exudate, whereas low protein content in the transudate. This is the basic difference. After this, we will discuss about different steps. In the second step, or the C5A leukotrienes, B4 bacterial product, what they basically do, they activate the neutrophil. Activation of neutrophil occur due to this, right? And neutrophil. So neutrophil are very important. Neutrophil are the first leukocyte, as I have already discussed, to enter the exudate. And when they enter the exudate, means neutrophil plus exudate, they accumulate in the exudate, so they will form the pus. So that pus is nothing but the combination of neutrophil and exudate. Okay, and when this neutrophil enter the exudate, so what is the function of neutrophil? It will kill the pathogen. This neutrophil will kill the pathogen by two method, you can say, or two mechanism. The first is the phagocytosis, and the next is the secretion of content of granule into the exudate. So there is secretion of some granules into the exudate. This will also kill the pathogen, and there will be the phagocytosis. As we all know that phagocytosis is primary and secondary lymphosomes, right? There is a formation. So these are the mechanism by which neutrophil will kill the pathogen. Now let's discuss how these neutrophils comes out, right? So neutrophils or other leukocyte, they will leave the capillary or venule and migrate into the tissue exudate. So you can see that they will migrate to the tissue exudate, and how they migrate? They will migrate in response to the chemoattractant molecule, and these chemoattractant molecules, as we have discussed in the tissue, they are from the host cell, either from the host cell, or they may be from the microbes, they may be from the foreign substance, and some neoplastic cell also secrete these chemoattractant. As there will be the greatest concentration of chemoattractant which is present near to the microbe or any other foreign substance, right? And this greatest substance near the, you can say that if this is microbe, there will be more chemoattractant around this, and as you go away from this microbe, the concentration of the chemoattractant will decrease. So this is the chemotactic gradient, chemotactic gradient, right? So this is the chemotactic gradient which will attract the neutrophils towards these foreign substance or neoplastic cell or the injured tissue, right? So there is leukocyte adhesion cascade. Leukocyte adhesion cascade, we will discuss that what is leukocyte adhesion cascade. This is important. So leukocyte, there are three steps. There are three steps in leukocyte adhesion cascade. The first step is a movement and attachment to the luminal surface of capillary and venule. As we have already discussed that these neutrophils will attach to the luminal surface. So this is the luminal surface, inside surface. So these neutrophils will attach to the luminal surface, and when they attach, after their attachment, the second step occur, migration through the intracellular junction formed between the gap between endothelial cells. So these are endothelial cell, and they form gap, and these you can see that this neutrophil is coming out through these gaps. So this is the second step, and adhesion is the first step. This is the second step, and after second step there will be the migration with the exudate up the concentration gradient to the source of injury. So they will move to the source of injury, and this is the third step. So these are three steps, and these three steps comes under the leukocyte adhesion cascade. So remember this term, leukocyte adhesion cascade, LAC, right? And after this leukocyte adhesion cascade, you can also see here that neutrophil adhere to the endothelium. This is the first step. Neutrophil pass through the endothelium and rough basement membrane. Second step in the leukocyte adhesion cascade, and we already discussed that they occur due to some chemicals, right? And then neutrophil migrate to the site of tissue damage. This is the third step. So these are three steps in the leukocyte adhesion cascade. And after this, what will neutrophil do? Neutrophil will phagocytose the bacteria or any other thing, kill bacteria, and phagocytose tissue debris. Okay, so they will clear the area. Okay, and there are several chemicals, other chemicals like serotonin or 5-hydroxytryptamine. We also call this serotonin 5-hydroxytryptamine. This HT is hydroxytryptamine, right? Histamine, C3A, C5A. C3A complement protein, C5A is also complement protein, bradykinin, leukotrienes. So these chemicals will activate the vascular endothelium, and this will increase the adhesion molecule on the endothelium, and it will ultimately increase the attachment of the or adhesion of the neutrophil to the endothelium, or it will increase the leakness of the endothelium, and due to this leakness there will be more plasma protein in the tissue. And this will when this this protein come into the tissue, so what will happen that these as we already know that immunoglobulins are also protein. So when they come in the tissue portion, they will opsonize the antigen. So what is opsonization? It is basically covering the antigen and making it more palatable for the phagocytosis, right? So it is nothing, you will read this in detail, this portion in immunology. So opsonization is nothing, making the antigen more palatable for phagocytosis. And there will be activation of complement protein, there will be inactivation of the organism, and there will be activation of complement component. So there is a cascade of protein in the complement. We will discuss this in separate video, right? So this is very complex and very long mechanism which occur. So this complement system will activate, and there is a formation of membrane attack complex. This MAC is very important. This MAC will produce the you can say pore. If this is a cell, this MAC will produce the pore inside the cell, and there will be the exocytosis in the cell. Due to this exocytosis, the cell will die. So this is the main you can say function of the complement. And fibrinogen, basically fibrinogen is the protein which is mainly responsible, and when it polymerizes it form the fibrin. And fibrin, what is the function of fibrin? Fibrin mainly localize the inciting agent which is present at the tissue site. So framework for the neutrophil migration, it will also provide the framework for the neutrophil migration, and the main function of fibrin is localizing that inciting agent. So if suppose that if bacteria is present here, so fibrin will cover this bacteria and localize this bacteria or any other inciting agent to a site, so it will not move towards other side, right? So this is the main function of this fibrin. So these are different steps in the acute inflammation. Now we will discuss about the key response of acute inflammation and the principle inflammatory mediators. So what are mediators that mediate the process? So these process, as you can see that this is a very complex process. So how this process will occur and what are the different chemical which mediate this process, we will discuss that. So the first is the vasodilation. So mainly vasodilation occur due to different chemicals like nitric oxide, bradykinin, prostaglandin and leukotrienes. Okay, then there will be the increased vascular permeability. Increased vascular permeability is due to the vasoactive amines like histamine, substance P, bradykinins, complement factors C5a, C3a, fibrinopeptide. You should not remember all these substances for your exam point of view, but remember, for knowledge you should remember these substances, okay? Because in pharmacology you will act on you should have a knowledge about these substances, because in pharmacology without having a knowledge of these substances you will not able to understand the concept. Prostaglandin, leukotrienes and substance P cytokines. So these are different chemicals which will increase the vascular permeability. And there is also smooth muscle contraction which is mainly due to the histamine, serotonin, C3a, bradykinin and platelet activation factor, leukotrienes. As you can see here that one substance can initiate different process, right? So you cannot say that histamine only increase the vascular permeability. Histamine can also increase the smooth muscle contraction. After this we have chemotaxis and leukocyte activation. Chemotaxis occur due to the complement factor and leukotrienes mainly, and chemokine defensins and different chemicals, and collagenous lectins, cytokines. You should not remember all these things, but for knowledge you should remember. And fever, as we have already discussed that there will be fever in case of inflammation. So this fever occur due to the cytokines, different cytokines like interleukin 1, tumor necrosis factor, interleukin 6 and prostaglandins. So this is important, that fever occur due to some cytokines and prostaglandin, right? And what are those cytokines? These are interleukin 1, tumor necrosis factor and interleukin 6. There will be nausea in inflammation, and this nausea occur due to the cytokines, and these cytokines are interleukin 1, TNF or tumor necrosis factor, and high mobility group of factor. As you can see that interleukin 1 and tumor necrosis factor, they produce fever as well as nausea, both things, right? And pain is produced by bradykinin and prostaglandin produce fever and also the pain. Tissue damage, neutrophil and macrophage lysozymes. So we have already discussed that neutrophil do phagocytosis, and this phagocytosis as we all know that this phagocytosis is a complex process, and there will be the removal of the lysosomes and granule. So this lysosomes or granules sometime will do the tissue damage, okay, and this tissue damage will occur due to this neutrophil or macrophage. After this phagocytic process, there will be the reactive oxygen species like superoxide anion, hydroxyl radical, nitric oxide. So they will also produce the tissue damage or responsible for the tissue damage. So these are different chemicals which are involved in the acute inflammation. You can remember only few things like how fever is produced, nausea, pain, tissue damage, but from your exam point of view, I don't think that these are very important, okay. After this, we have vascular changes of inflammation. In vascular changes, we have different steps like change in blood vessel, change in rate of blood flow, change in blood stream, and exudation of plasma, emigration of leukocyte, and diapediasis of erythrocyte. This question is very important, and this question your teacher can ask these questions, okay. So remember, these questions are important from your university point of view, okay. So prepare these questions in detail. Change in blood vessel, so there is momentary vasoconstriction as we have discussed. There will be the vasodilation. After this, change in the rate of blood flow. So this change in rate of the blood flow is due to the slowing of the circulation, stresses, and increased vascular permeability. And due to this increased vascular permeability, there will be the transudation or formation of transudate, and there will be change in the blood stream, exudation of plasma, emigration of leukocyte, and diapediasis of erythrocyte. We have already discussed this vascular change, right? After this, we have principal mechanism of increased vascular permeability in inflammation. Basically, what is the mechanism behind the permeability in the inflammation, vascular permeability in the inflammation? We will discuss it. So the first is the normal situation in which leukocyte and plasma protein present inside the blood vessel, right? And this is endothelium. And in the second situation, B situation, there is a retraction of endothelial cell. Basically, this retraction of endothelial cell mainly occur in the venule, and it is induced by histamine, nitric oxide, and other mediators. The important thing about this retraction of endothelial cell is that this is rapid and short-lived mechanism. So what happened in this, that there is, you can see there is retraction of endothelial cell, and when this retraction occur, what will happen? These gaps will widen, and when this gap wide, there will be the exudation of this plasma protein and leukocytes, right? After this, in C situation, we have endothelial injury. In endothelial injury, basically this occur in the arterioles, capillary, and venule, and it is caused by burn and some microbial toxin. It is rapid in nature and may be long-lived, and you can see that the structure of endothelium is change in this type of injury, endothelial injury, and due to this there is a similar phenomena occur, means exudation of the protein and leukocyte occur. After this, we have leukocyte mediated vascular injury, in which this leukocyte will attach to the endothelial cell, and this mainly occur in the venule and pulmonary capillaries, and it is associated with the late stage of inflammation. It is usually long lived. Increased transcytosis. This transcytosis occur mainly in venule, and it is induced by vascular endothelial growth factor VEGF. So there will be the more transcytosis and movement of protein, but there is no movement of the leukocyte in this. Next, we have cellular changes of inflammation. This is very important question. And in cellular changes of inflammation, there is a exudation of leukocyte and phagocytosis, two main mechanisms. And in exudation of leukocyte, as we have already discussed, there is change in the formed element of blood. There is rolling and adhesion, emigration, chemotaxis. We will discuss this in detail also, right? After this, there is phagocytosis, and in phagocytosis we have recognition, attachment, then engulfment, and killing and degradation. So now we will discuss about this portion, exudation of leukocyte cascade mechanism. So we will call it leukocyte cascade mechanism. We will not discuss this mechanism in much detail, just a brief portion, but you are not required to learn all these things, right, for your university point of view. So when this leukocyte, read this, that leukocyte have different receptors and endothelial cell also have different receptor. Okay, so what happen is that when these two receptor, endothelial molecule and leukocyte receptor, when they combine, there will be the rolling and other mechanism of leukocyte. Okay, so this is leukocyte, and this leukocyte have different you can say receptor, like Sil-Lewis X modified glycoprotein. You are not required to learn all these things, right? Integrins, when they bind to P-selectin, E-selectin, so these are present on the endothelial cell. When they bind to them, there will be the rolling or the movement of leukocyte along the endothelium. So this is basically the attachment and stable adhesion. Then this leukocyte will move from the endothelial gap to outside. And there will be attachment of fibrin and fibronectin are also present outside them, and attachment of leukocyte also occur with that. So there are several molecules through which these leukocyte will attach to them, and they will produce cytokine. Different mechanism are there. So we will not discuss in that much detail. You just have to remember that there are different receptors which will bind to endothelial cell receptor, and there is movement or rolling, you can say, along with endothelial lining, and then this leukocyte will exit like this, only this much. So there are several chemicals which are involved in this process, like IL-8, interleukin 8, IL-1 beta, interleukin 1 beta, TNF, PACCAM, platelet endothelial cell adhesion molecule, platelet activating factor, ICAM, intracellular adhesion molecule. So there are different, but you are not required to remember all these for your university point of view, right? Formation of transudate and exudate. So this is very important, how transudate or exudate are formed. So this is the normal condition. In normal condition, there is balance between the hydrostatic pressure and the colloidal osmotic pressure. So hydrostatic pressure comes due to the plasma protein, you can say, and colloidal pressure comes outside from the outside. So the direction of both the pressures is opposite, right? But in case of transudate, there will be increased hydrostatic pressure, and there will be the decreased colloidal osmotic pressure. So what will happen? The fluid will leak out, because this pressure is more and this pressure is less, and this decrease in colloidal pressure occur when there is liver disease. If there is liver disease, then what will happen? There will be increased protein loss, because you may know that liver is the major site of protein production, right? If there is any liver disease, then there will be low production of protein. There will be more loss, and if there is more loss of protein, and if protein is not present in the blood, then there will be decreased colloidal osmotic pressure, and if this decreased colloidal osmotic pressure occur, then there will be fluid leakage, and this will produce the edema also, right? And hydrostatic pressure increase in congestive heart failure. Okay, then there will be exudate. We already discussed what is the difference between transudate and exudate. Okay, so as you can see that in transudate there is less protein, right? But in exudate there is more protein outside. So in exudate, fluid and protein leakage occur, and vasodilation and stresses present in the blood vessel, and increase intraendothelial space. This is inflammation. So basically in inflammation, this exudation mainly occur, where leukocyte and the protein both there is a leakage of both the things, right? And the widening of gap also occur. In transudate stage, there is less widening between the gaps, you can see, but there is more widening in the exudate portion. Okay, there are different cells, effector cells you can say, of acute inflammatory response, and this includes the vascular endothelial cell, the most important cell, and mast cell and basophils, which produce different chemicals which are involved in them, and neutrophil. It is the most important, in fact, cell of this acute inflammatory response. Eosinophil, natural killer cell, monocyte, and macrophages mainly do the phagocytosis, right? Next, we have chemical mediator of the acute inflammatory response. These include the histamine, serotonin, bradykinin, trachykinin. Repair, regeneration, and fibrosis after injury and inflammation. So we will discuss how this inflammation help in the repair after injury. So now we have done everything. Okay, we just neutralize the antigen or the foreign substance, and we just, you know, clear the area. Now what we have to do, we have to clear the battleground. Exactly, we have to clear the battleground, or the you can say the destruction which occur in the battleground or the tissue, respective tissue. Battleground word is just used for better understanding. Battleground is nothing but the tissue which was inflamed, right? So when injury occur, there is cellular and vascular response, which we already discussed. So when this cellular and vascular response occur, there are two conditions. The first is stimulus remove, which is acute injury, or it may persist. When it will persist, there will be the chronic inflammation, which we'll discuss later. So leave this part. Okay, we are discussing just this part. So when stimulus remove or acute injury, the parenchyma cell, the parenchymal cell death occur, but there may be the intact tissue framework. The tissue framework may be intact, or it may be damaged, right? And intact in case of superficial wound, some inflammatory process, there will be the intact tissue framework, but it will be damaged when there is deep wounds, right? If it is intact, then there will be regeneration, restitution of normal structure. An example is liver regeneration after partial hepatectomy, and superficial skin wound, and resorption of exudate in lobar pneumonia. But in case of deep wounds, repair and scar formation occur. Remember this, in case of deep wound, scar formation occur, but scar formation do not occur in normal or superficial wound. Examples are deep excisional wound, myocardial infarction. There is formation of a scar, right? So the outcome, basically I should say, the outcome of the acute inflammatory response is either resolution. It may be either resolution, it may be healing after the healing by fibrosis, you can say. It may be the abscess formation, third may be the abscess formation, and fourth may be the progression to chronic. So this is the last sequelae, and it is the progression to the chronic condition. So these are the four conditions for outcome, you can say, of the acute inflammation. But the desired outcome is this. Desired outcome is resolution. Okay, so resolution occur if the following I will discuss following events when occur. The following events are like the acute inflammatory response is completed in the correct way, sequence. Then macrophage and lymphocyte remove the exudate. As we all know that macrophage and lymphocyte will remove the exudate, the exudative part, and the inciting agent is also eliminated because of phagocytosis. The stroma and the connective tissue of the affected portion of the tissue can be provided for regeneration of the epithelial cell. Okay, so the whole mechanism of resolution will occur by this. And there is a diagram. Event in the resolution of inflammation: return to normal vascular permeability, drainage of edema fluid and protein into the lymphatics. Pinocytosis occur. This extra protein will go inside the macrophages by the process of pinocytosis. Phagocytosis of apoptotic neutrophils, phagocytosis of necrotic debris, and disposal of macrophages. We'll discuss this portion via diagram, very good diagram. So this is blood. When there is exudation of three things. What are these three things? Fluid and protein, monocyte and neutrophils, right? So it is the exudation, and this exudation should be prevented for the reparation, for the resolution. So the first step is the return to normal vascular permeability. Okay, after this, second step there will be the drainage of edema. There will be the drainage of edema fluid and protein into the lymphatics. So there will be the drainage into the lymphatics, and if some protein or fluid may remain, then the third step will occur. This protein or edema fluid will go into the macrophages. You can see this will go into the macrophages. This is the third step. Okay, after this we have fourth step, that is phagocytosis of apoptotic neutrophils. When this neutrophil phagocytize the inciting agent, this neutrophil again phagocytized by the macrophages. This is the fourth step, right? And this monocytes, these monocytes only mature and converted into the macrophages. Okay, as we all know. Then there is phagocytosis of necrotic debris also. If there are some necrotic debris, they are also phagocytosed by this macrophage. And disposal of macrophage is the sixth step. As you can see, there is a central role of this macrophage in whole reparative process. And macrophage also release some growth factors which are responsible for the stimulating. Basically, these growth factors stimulate the fibroblast and new blood vessel formation may occur. So this is the central role of macrophages in the reparation phase of any inflamed tissue. Okay, now we will discuss about the morphological classification of exudate in acute inflammatory lesions. So basically, you can say acute inflammation, or you can say the division of acute inflammation is on the basis of type of exudate, right? And on this basis, on the basis of histopathological lesion of acute inflammation, they are most commonly grouped into 5 categories. These are, the first is the serous, catarrhal, fibrinous, superative, or hemorrhagic. We will discuss it one by one, right? Number 1 is serous inflammation. In serous inflammation, there is accumulation of fluid with low concentration of plasma protein. And as we have already discussed, that when there is low concentration of plasma protein or no to low number of leukocyte, the substance is known as transudate. It is known as transudate, right? It is not exudate. So the watery material is released from the small gap between the endothelium from the hypersecretion. It may be or it may be from the hypersecretion of the serous gland, which are inflamed, right? And as we all know, that transudate has specific gravity is less than 1.012, right? So the transudate is released from serous gland in case of serous inflammation, and it may be due to the thermal injury to skin, such as burns or photosensitization, which we will discuss, right? In which the fluid filled blisters will appear, and in Hindi we call it chala, fluid filled blisters. And it may be due to the acute allergic response, which is characterized by watery eye, runny nose with clear, colorless and clear transudate, you can say. After this, we have gross lesions. For example, with serous inflammation consist of containing excessive clear to slightly yellow watery fluid. In gross lesions, we have small blisters contain excessive clear to slightly yellow fluid or watery fluid that leak from the tissue on the cut section. And apart from this, we have raised fluid filled vesicle which are protruding above the surface of mucous membrane, or it may be from the nasal cavity of the animal also. After this, we have some microscopical features in which the connective tissue fiber are separated widely, and capillary and post-capillary venule are dilated with erythrocyte, which is known as active hyperemia, right? And endothelial cell lining may be hypertrophied, their size may increased or maybe not. Okay, so in the image, as you can see, that the sheep is having photosensitization. She or he may be photosensitized, and The non-hair skin of nose is covered by a crust resulting from the dehydration of the serous exudate. So there is a formation of crust. The lesions are crust-like, and this crust is formed due to the dehydration of the serous exudate. And you can also observe the ears. The ears are edematous and droopy. These are the gross lesions, and while we are talking about the microscopic lesion, so you can see that there is dilution of post capillaries, which is known as active hyperemia, and there is edema. You can see the edematous fluid. Edematous fluid appear pink. Our next part is the catarrhal inflammation. In catarrhal inflammation, it is also known as mucoid inflammation. It is also known as mucoid inflammation, right? So catarrhal inflammation or mucoid inflammation basically used to describe a pattern of acute inflammation in which you will find that tissue response the accumulation of the thick gelatinous fluid, and it contain basically mucus and mucin, which is from the mucous membrane. This response occur most widely in the tissue with abundant goblet cell and the mucus gland. Okay, so and after this this type of inflammation you will see in case of chronic allergies or autoimmune gastrointestinal diseases. And if I talk about the gross and microscopic lesion, so this is gross lesion and this is microscopic lesion. In gross lesion or cut surface, the affected tissue may be covered with clear or slightly opaque thin fluid. It is not like the serous inflammation in which the fluid is somewhat watery, but in catarrhal you will see the fluid is opaque, okay, slightly opaque and thick fluid. While we talk about the microscopically, the lesions can include the hyperplastic epithelial cell of the mucous gland, and the connective tissue fiber may be separated by mucin because of accumulation of the mucus, right? And in this diagram you can see that there is a glistening layer of the clear mucus, and as we have discussed, the fluid is slightly opaque. It is not so clear as in case of serous inflammation, and there is also nodular appearance in this. By the way, this is the diagram of abomasum of cow, and you can see the epithelium is moderately thickened and nodular appearance caused by the accumulation of a mucinous secretory product in the gastric pit. So when there is accumulation of mucinous secretory products in the gastric pit, there will be the formation of nodules, okay. And the second microscopic diagram is of colon of cow, and this is the case of catarrhal colitis. Hyperplasia of mucosal epithelial cell occur in this. You can see there is increased accumulation of mucus in this portion. Now we will discuss about the fibrinous inflammation. In fibrinous inflammation, basically the term fibrinous inflammation is used to describe a pattern of acute inflammation in which you will see the tissue response consists of accumulation of fluid with the high concentration of plasma protein. It is not like serous inflammation in which low concentration of plasma protein was present. In this there is a high concentration of plasma protein, okay. And apart from plasma protein, there is no to low number of leukocyte which is responsible for the response of an exudate, right? And in fibrinous inflammation occur with more severe endothelial cell injury that allow the leakage of large molecule weight proteins such as fibrinogen in case of fibrinous inflammation. And this leaked fibrinogen from the capillary and post capillary venule during fluidic phase of acute inflammation, which we have already discussed. It get polymerized out of the vessel to form the fibrin, and this fibrin which is a homogenized vivid pink eosinophilic protein, this cause the localization of any infectious material, right? And when this fibrin accumulate in the pleura, we call it fibrinous pleuritis. When this fibrin accumulate in the pericardium, we call it fibrinous pericarditis. When this fibrin accumulate in the fibrinous in the peritoneum, we call it fibrinous peritonitis, and like that. The most common example of this fibrin deposition is the Mannheimia hemolytica infection, in which there is a fibrinous pneumonia is present. Okay, so if someone asks that give an example of fibrinous inflammation, then it is the fibrinous pneumonia in case of acute Mannheimia hemolytica infection. Okay, so and now we have two terms, fibrinous pseudomembrane and hyaline membrane. These terms are very important, fibrinous pseudomembrane and hyaline membrane. Fibrinous pseudomembrane is the membrane which is formed when fibrin form a distinct layer which is covering an ulcer. It is known as fibrinous pseudomembrane. And when fibrin it lines the pneumocyte surface, basically when the fibrin lines the pneumocyte surface of lung alveoli in a peculiar fashion which is known as curvilinear, when it lines in curvilinear fashion and is mixed with necrotic cell debris, it is known as hyaline membrane. So this hyaline membrane is very important, right? So what is hyaline membrane? Hyaline membrane is formed when the fibrin line the pneumocyte surface of lung alveoli in a specific fashion which is known as curvilinear fashion and is mixed with necrotic cell debris is known as hyaline membrane. It basically occur in the BRSV infection, and the full form of BRSV is bovine respiratory syncytial virus infection. Okay, and if I talk about the gross lesions in case of fibrinous inflammation, then there will be redness which is due to the active hyperemia, and the exudate texture is thick, stringy, elastic, white to gray to yellow. And if I talk about the microscopic examination, then there will be obviously active hyperemia as we have seen in gross examination, and there may be the hypertrophy also. And sometimes the fibrinous exudate rapidly infiltrated by the neutrophils, which will result in the fibrinous-suppurative inflammation. You will hear this term fibrinous-suppurative. So fibrinous-suppurative inflammation is nothing but when fibrinous exudate is infiltrated by the neutrophils, it will form the fibrinous-suppurative inflammation. Okay. And in this diagram you will see that it is the fibrinous inflammation present in the pleural cavity of visceral and parietal pleura of horse. Okay, so in the first diagram or A diagram, you can see there is a yellow gray thick friable exudate, and it is formed consists of fibrin which is mixed with the plasma protein. So this is the fibrin which is mixed with the plasma protein present. And in case of microscopic examination, there is a focus of bacteria. You can see this is the focus of bacteria, and along with the focus of bacteria there is also red material which is fibrinous exudate. Okay, so this is the microscopic picture of fibrinous inflammation. Now we'll discuss about the suppurative and the last part of inflammation. In suppurative inflammation, the term is used to describe a pattern of acute inflammation in which you will see the tissue response consists of the accumulation of fluid with a high concentration of plasma protein. So basically the plasma protein is high in this. You should remember this, and the leukocyte number is also high in this, mainly the neutrophils. So the neutrophil is the main cell which predominate in suppurative inflammation. Okay, and now the term pus come. So what is pus? The pus is a cream liquid, but if it is dehydrated, it become more caseous. So a pus is nothing but a dense neutrophil accumulation. So a dense neutrophil accumulation is known as pus, okay, which we commonly use. And collection of pus by a fibrinous capsule is known as abscess. Collection of pus with the fibrinous capsule is known as abscess. Abscess can be seen grossly, but when these abscess size is very small, it is not seen by naked eyes or grossly, we called it micro abscess when size of abscess is very small. Okay, and so this is the part of a suppurative inflammation. And the examples of suppurative inflammation are abscess in the brain of horse in case of strepto equi infection, very common infection. And apart from this, in case of cattle or cow, micro abscesses are found in the brain of cow by the Listeria monocytogenes. So you will read in detail about these bacteria. The first is the strepto equi and the second is the Listeria monocytogenes. Okay, and so these bacteria will cause the abscess or micro abscess. If I talk about the gross lesions in case of suppurative inflammation, the gross lesions include the accumulation of pus which may be mixed with fibrin, and the pus, the area may be hyperemic, and which is covered by a thick white, gray, yellow pus. Okay, if I talk about microscopically, then there is large number of neutrophil, which is the main and peculiar character of the suppurative inflammation, and many degenerated neutrophils are also present. And apart from the neutrophil, there is a debris, bacteria and plasma protein also. If I talk about this diagram, that you can see that this is the diagram of suppurative inflammation, secondary bacterial infection of bronchopneumonia in case of infectious canine distemper of puppy. You can see that the cranioventral area of lungs are firm and begin to brown. This is the cranioventral area of lungs, which is firm, brown, and lesion is caused by neutrophil, which are transmigrating into the alveoli. So you can see that the color of this region is not normal. Okay, and this is due to the suppurative inflammation, and which occur due to the transmigration of the neutrophil into the alveoli. And you can see microscopically that alveoli contain numerous neutrophil, which is suppurative exudate and slot pneumocytes. I know that the neutrophils are not so clear, but you can, if you focus on this part, then you can see the lobes in the nucleus of the neutrophil. Okay, I know that it is not so clear, but you can understand that in suppurative inflammation there is accumulation of neutrophil. Okay, so with this acute inflammation topic and here, and thank you for your patience listening, and keep supporting, keep loving, subscribe to Vet Study.